Hi everyone, my name is Caitlin Galuli and I chose to do my presentation on dizziness. Dizziness is a common, non-specific term used to describe a variety of subjective states with varied causes. The most frequently used categories of dizziness are vertigo, unsteadiness, lightheadedness, and disequilibrium. And there are multiple causes that can cause vertigo and dizziness. And some of these include psychiatric causes, neurological causes, cardiovascular, medications, sensory deficits, peripheral or central vestibular disorders, or mixed pathologies. And also another big one is benign paroxysmal positional vertigo, and this is very common in elderly people. Dizziness is a common symptom reported by older adults at primary care visits, and actually an estimated 30% of age group 60 years and older have this, and it increases to greater than 50% in individuals over the age of 85. So when these people come to the clinic or primary care or hospital, wherever they're going, it's super important to have a very thorough assessment to rule out all of these different types of things that could cause it, like stroke versus an ear infection or a heart attack or anything going on with the heart. But things that are very significant in healthcare are falls that are very common with vertigo and dizziness, functional decline, and depression. So what is the significance of dizziness and vertigo in nursing? Well, nurses and nurse practitioners have a huge job when it comes to the physical exam and the interview because each patient reports their symptoms differently and dizziness is so subjective, so it's going to be different for each patient. So some of the questions that the provider should ask are symptoms that trigger or triggers for the symptoms, relieving or aggravating factors, a pattern for symptoms, and also just associated symptoms in general. And a big part of this interview is the medication review, because there's so many different medications that can cause dizziness symptoms. As nurse practitioners, we also have to recognize that elderly are at great risk for symptoms like dizziness because of their advancing age. And a word that I noted earlier, it's called presbystasis. It's an age-related disequilibrium that cannot be attributed to any pathology and is characterized by a gradual onset of difficulty walking. So this is something that we'll also have to notice when the patient comes in and just look at their general appearance and if they're holding on to any walls or struggling to get around, and it's just a big part of the safety issues that we'll talk about later as well. This is our patient who came into the clinic a couple weeks ago. He was complaining of a 2-day history of these dizzy spells, and he did describe it as vertigo. So he described it as episodic, short, and they were sporadic episodes where the environment felt like it was spinning. And it was continuous, and it didn't really depend on his position. It was just kind of intermittent when this happened. Here you can see his listed medication. So he does have heart history, and he had knee surgery, so he still has some pain, takes naproxen. And Bumex, which we'll talk about later, are also ototoxic medications, just the Bumex and naproxen. Otherwise, he is a healthy man and just looking to get some help. Here we have other common symptoms that clients with dizziness or vertigo may report. You can see them right here: nausea, vomiting, tinnitus, ear fullness, hearing loss, sweating, and heart palpitations. In this patient's case, he just felt dizzy and lightheaded when he was moving. And with the summer heat, he's been working outside in his garden, mowing his yard. He's still a young elderly male, but he did say that he's lost 5 pounds and he was relating it to just being outside more. Here we have the review of systems before we did the physical assessment, and I'll kind of just discuss the positive findings of the assessment or interview. So he first stated that he did lose weight over the past 2 months, vertigo, mild hearing loss over the past 3 weeks, and this is also related to his dizziness. He was feeling palpitations during the episodes, and again under neuro, dizziness, vertigo, and lightheadedness. Some notes I wanted to mention were that Bumex and any NSAIDs, so in his case naproxen, they are autotoxic. And under the neuro, I noted that dizziness is more prominent when changing positions, and it resolves when motionless. Here we have the patient's objective data, and the first thing we did was check orthostatic blood pressures to rule out postural hypotension, which can cause vertigo. And in this patient's case, he does not have it. All of his vital signs are within normal limits. He is just not looking good in that picture though. Here we have more objective data in the general assessment, and I won't go over everything because generally the patient looked okay, appeared well, but I wanted to note the positive tests that were found on the neuro exam. And this test is called the Dix-Hallpike maneuver test. And what it is, it tests for benign paroxysmal positional vertigo, or BPPV, which is very common and it can definitely cause vertigo. So this Dix-Hallpike maneuver, it's something that physical therapists do at the clinic I'm at. So they were able to take this patient and put him in different positions and almost elicit a dizzy vertigo sensation and check for nystagmus. And when they put them in this position, they can repeat those and help to resolve these symptoms. And they can bring them back over a couple weeks and continue treatments, but sometimes it can be resolved in just one time. So this BPPV, what it is little crystals of calcium carbonate. It's in the inner ear, and when it's dislodged, it can migrate into the semicircular canals. And when the head moves, the gravity-dependent movement is affected, and it causes displacement and a sensation of vertigo. Here is a list of differential diagnoses for dizziness, and we mentioned the first one, BPPV, and this is ruled out or confirmed by the Dix-Hallpike maneuver. Vascular insufficiencies, which is ruled out by orthostatic blood pressures, auscultation of the heart, and carotid bruits, and EKG. Meniere's disease, which is ruled out by careful and thorough physical and H&P, and the Weber and Rene test and an audiogram. Labyrinthitis is ruled out by positional maneuvers, positive VOR test, and audiometry. And also in labyrinthitis, these patients can look acutely ill. And this patient, in this case, he presented himself looking well. And also another differential is autotoxic drugs. And this is ruled out with audiometry. In the case of our patient here, we did have positive findings on the testing that did show positive BPPV, which can be treated with different positioning. So that is the first line treatment. But the first thing I wanted to mention were the two medications that he was on, the Bumex and naproxen. But this could be tested with audiometry from an ear, nose, and throat specialist. So this actual step may not even be necessary because he was positive for BPPV. But because this patient has been outside, he's been losing weight, it's still encouraged. You still want to encourage him to continue drinking plenty of fluids, getting lots of rest, and still monitoring his weight because he does have the history of CHF. Again, the most acute vertigo symptoms and BPV, they do resolve spontaneously. So that would need to be said to the patient. Here we go. We have the final diagnosis, which we pointed out earlier, benign paroxysmal positional vertigo. The pertinent positives in our findings was positive Dix-Hallpike maneuver. The patient did not have any ringing or tinnitus in his ears or hearing loss. Lateral rotary nystagmus with position change was positive on the procedure or the maneuver. The symptoms did wax and wane. They were not continuous, and the patient did have relief when he was not moving. Some of the challenges on this patient is that he is at increased risk for orthostatic hypotension with his use of the loop diuretic, and he is also on 2 different medications that can cause ototoxicity, which can result in dizziness. There's actually an organization that provides support for people with vestibular disorders such as dizziness or vertigo. It's called the Vestibular Disorders Association. And another big resource is obviously a ENT or a neurology doctor or provider, whatever is appropriate for this patient, which could also pose a challenge, whether it's getting to that appointment or following up with that appointment. More discussion notes are noted that the patient did not have any health behaviors that were to cause this. He did have positive nystagmus with position change, but other than that, he did not have any behaviors. Social determinant of health identified, there were none. He does have social support. He does live with his wife of 50 years and has 3 children with grandkids. Socioeconomic factors to consider: health literacy, travel to specialists, and cultural factors. Legal and ethical issues considered are misdiagnosis, because there's so many different objective symptoms, and this just has to be such a thorough exam for it to be diagnosed. And also sending a client home without conducting home safety assessment, because these patients are at such a high risk for falls. In conclusion, dizziness is very common. It's more common in women, and it increases as people age. It is a subjective phenomenon which is described differently between every person, and a thorough history will often differentiate the type of dizziness being experienced. So it's helpful to make note of how the patient describes it. The thorough medication assessment is very important to rule out any medications that could be causing these symptoms. And older clients may need assistant devices during these acute episodes, which goes along with the home safety assessment, because you would not want to send someone home who is at risk for falls, like we mentioned earlier. So this would definitely need to be done. The last thing I wanted to mention is that vertigo can be very frightening. So it's important to provide information about the evaluation, the prognosis, and the different treatment options to alleviate the patient's fears and, just to alleviate their fears of this condition. So it's important to emphasize the effective treatments, which are vestibular therapies and exercises, which can also increase the symptoms at first, but the treatment must continue for the symptoms to subside. So it's very important to reassure the patients when they have dizziness.